We're going to hear one more perspective. We'll go across the pond to England, and Sue Hill is here to tell us about Genomics England as an exemplar of implementing on a national level. Sue.
Thank you very much. I'm really delighted to be here. I'm just sorry that I'm not as well as I hoped to have been. What I'm going to talk about is really the driver project that's Genomics England and the 100,000 Genomes project, and how in 3 years it's really driven major decisions within the healthcare system and what will be the implementation of a new genomic medicine service from October 2018. So this is the overview of the 100,000 Genomes project, so focused on whole genome sequencing in rare disease and in cancer. Of the 4 principles that were established at the very beginning was that whole genome sequencing would extend the current NHS diagnostic repertoire, and recognising that the NHS in England is a single payer system that's free at the point of access. But that recruitment to this project would be from routine care with patients treated through routine channels, so that it would start to embed genomic medicine from the participation in the project. And along the bottom of this slide, you'll see what it is the NHS has had to contribute, both from identification of patients consenting, but also the collection of high-quality samples, the provision of data, and then eventually the validation of findings for clinical feedback. What we did in NHS England was establish 13 NHS genomic medicine centres covering the whole of the NHS in England and populations of 3 to 7 million. By the end of this driver project in 2018, there will be 90 hospital organisations that have been networked, and this is out of a total of around 200 hospitals. So that's part of the challenge in thinking about implementing a more comprehensive service for the future. What we did associated with really quite stringent contractual requirements is insist on all of those 13 genomic medicine centres working to common protocols, including for consent, but to agree to data sharing across their networks, to how they collated data and submitted data to Genomics England against agreed data standards and data sets. And we've had national networking from the very beginning, so from 2015, when we established these genomic medicine centres to share best practice. This is just a schema of really the data flows within the 100,000 Genomes project. It highlights really the complexities of the data flows, even when that data flow has come together in 13 data hubs within our 13 genomic medicine centres. So on the right-hand side, it just illustrates that in one single organisation to populate one single data set for an individual patient, up to data's had to be pulled from up to 600 individual systems. And so if you think about what this means in terms of 90 organisations that will be involved in the project to the end, but also what we need to build for the future in our 13 genomic medicine centres, and how this needs to link with the data coming from Illumina, the whole genome sequence provider, and flow into the National Genomic Database that Genomic England have developed. This has been a complex data project, and one that's taken the NHS on a journey in terms of both their collection of data and also their submission of data. I put this slide in for a very particular reason. One, it's really demonstrated the NHS can and will share data. Secondly, because of the creation behind that NHS firewall of a de-identified data space, it's also shown how data that can be collected in this project can be used on the left-hand side for clinical care purposes, but on the right-hand side for application in research projects, but also in a pre-competitive industry consortium, which is important when we think about our plans for the future. This just summarises the 100,000 Genomes project progress and where we are to date. So over 62,000 samples have been collected from the NHS. So there's been over 62,000 consent conversations. We're currently recruiting and collecting samples at the rate of almost 1,000 a week from the NHS, from routine care in England. And Genomics England have operated a cancer fast-track programme such that 60 cancer samples have been collected and turned around in terms of through whole genome sequencing in 20 days. So far we have just over nearly 36,000 whole genome sequences that have been available, and you can see that the bulk of those are in rare disease. And on the analysis and report side, Augusta Rendo Dunn and the team have been working really hard to send out reports to nearly 3,000 families. What has been really important, though, is the actionability, so a greater diagnostic yield of around 20 to 25% in terms of actionability over and above NHS standard care to date, and that's what's enabled us to make a compelling argument. And now 18,000 genomes are scheduled for movement into the Research Embassy in October 2017, and this represents really hard work from Mark, Peter Counter and Augusto. And what I wanted to say from the very beginning is Mark Caulfield and myself have worked really, very hard to ensure that this project is aligned very carefully with the NHS and the broader aims of this project from the very beginning and as we go forward. And so we're using every opportunity to work together and to establish the right environments for the future. So now we have, in terms of establishing a service for the NHS in England from next year, we've demonstrated proof of concept for routine care. We've demonstrated the feasibility and affordability of whole genome sequencing within our whole genomic testing repertoire. We've demonstrated that we can obtain consent for multiple purposes of that de-identified data, and that there's an agreement in the NHS to data share for multiple purposes instead of just holding it at the level of individual laboratories or individual clinicians. We started to standardise processes, pathways and data flows, and they're being embedded. We've got the beginnings of a total system-wide involvement of the NHS in England. We've got the clinical leadership in place that shouldn't be underestimated for trying to achieve something like this. And we're starting to align the National Health Service's system planning and commissioning with the outcomes from this project. In March of this year, I took to the board of NHS England our proposals for a genomic medicine service in England to support these principles on the right-hand side that includes ensuring comprehensive and equitable access for the entire 55 million population in England from October 2018, and I'm going to come to that in a minute. But also that what we want to do through this initiative is really to improve the quality and access of care, the value and the sustainability by linking the genomic diagnosis and other next generation diagnostics with our ability to introduce personalised treatments and interventions, given we have a rising budget of getting on for £21 billion in the NHS in England spent on drugs because we don't match our diagnostic and our treatment outcome with that drug intervention. But also, part of our future service will be to support learning, research and development, including collaborative partnerships, and continue to build our political, ethical and moral trust in the use of genomic data. So these are the building blocks that we've been assembling. We're actively in a consultation and procurement stage. We will be reprocuring our genomic medicine centres and genomic clinical services for the future. And that will be very much linked to being able to deliver improvements in personalised medicine. We're establishing a new national genomic laboratory network such that there will be only 7 genomic laboratory hubs, and that will be inclusive of rare and inherited diseases and cancer genomic testing. We're introducing a new national testing strategy, which I'll come back to, including an annually refreshed testing strategy from single gene to whole genome sequencing, both for rare disease and for cancer. In the middle, there's an architecture and a set of services that will be developed in conjunction with Genomics England, including the informatics architecture and data store, the whole genome sequencing provision, procurement, and the NHS requirement will be brought together for requirements for research and other projects and endeavours, and with an ongoing semi-automated clinical interpretation pipeline for providing tiered variants back to the NHS. And on the bottom here, it recognises the importance of ongoing workforce development with Health Education England, and also a set of industry, academic and international partnerships, including new partnerships that will arise through a new life sciences sector deal that's been led by Sir John Bell and will include new cancer genomics projects and new projects that link, for example, digital pathology. On the left-hand side, what will be really unique is that we're introducing in NHS England a new genomics unit. There will be commissioning, coordinating and oversight function of this whole process with a new programme of care and a fixed budget for genomics in the NHS for the very first time. You can see we're in the middle of an active procurement now of many of these components. It'll be operational from Q2 18 and fully mainstreamed by Q2 of 2019. I thought I'd say a few words about the National Genomic Test Directory. This is a new development, the first time that genomic tests will be mandated in terms of what needs to be done in a standardised way across the whole of the NHS. As I said earlier, it covers the whole spectrum, and it will over time include all of the other functional genomic testing as the evidence suggests that they need to be included. It will be structured by technology, test name, test scope, targets and genes and clinical indications, and it will be refreshed annually, and annually on the basis of the available evidence and review by experts, including, I hope, international experts and many of you in this room. The development of the directory is on the right-hand side, and together with Genomics England, we've developed methodology that takes the best of what's available in evaluating genetic technology for application in clinical care purposes, and has developed that further such that there's a clinical assessment element to it and also an operational assessment that looks at the ability to provide an increased diagnostic yield in a more affordable and quicker outcome for the system. We initially expect whole genomes to be available from October 2018 for 28 rare disease categories and for a small number of cancers. And as the evidence evolves each year, this will be refreshed and more conditions added and more cancers. This is all, though, on the basis of whether this is or isn't affordable. On the right-hand side, you can see the 21 categories of technologies that will be utilising and introducing as standardised, and this will drive our reimbursement model. If the wrong test is applied for the wrong clinical indication at the wrong time, there won't be any reimbursement. So this is driving this very actively. And the proportion, for example, between what's done by large panel and what might move to whole genome sequencing will be a dynamic and changing process. For cancer genomics, we expect the bulk of it will move systematically across the NHS to doing more small or large targeted panels. You can see that on the basis of the work that we've done to date, that through the assessment of clinical utility, efficiency and effectiveness, up to 25% of our existing technologies will be replaced by newer technologies, particularly up to the level of either larger panels, whole exomes, or indeed whole genomes. And these 7 laboratory hubs will act as a national testing service, and they'll all do the same to the standard set of protocols and to outcomes. And we will gather further evidence on cancer through the related research track that we envisage under the life sciences strategy. So this is our new model of genomic testing undertaken by the genomic laboratory hubs, with whole genome sequencing done by what we anticipate to be a single provider and procured by Genomics England. But all of that data, non-whole genome sequencing and whole genome sequencing, will flow into one NHS data warehouse and reports portal. And that will be available to drive at a national level variant interpretation and reporting, include through, for example, national MDTs, but also to involve expert input from the international clinical and research community, particularly when it flows from what is the NHS data warehouse, which will have patient identifiable data, into the UK genomic database of de-identified data. So this will be a really dynamic process to inform and further enhance the outcomes for patients. This is a summary of the informatics and data infrastructure that we expect to be put into place. And this is with apologies to Peter Counter in terms of representing it in this way, but this is a schematic way where people, and certainly our sort of policy and managerial teams, understand. What we know is if we left it to the NHS to introduce, to apply and develop all of the informatics systems to encompass over 200 NHS hospital organisations and to interface with primary care. This wouldn't happen, and it wouldn't happen in a standardiser way to eventually allow data sharing to be something that drives enhancement for clinical care, but also to drive our research and development aspirations. So we plan to introduce a national genomic diagnostic information platform that will be used across the whole of the NHS. This will inform and feed data into the NHS data storage, which was being built by Genomics England, and when the consent is available, into the UK genomic knowledge base. And this will be populated, as I've said earlier, by both non-whole genome sequence and whole genome sequence data. There's a number of different elements that this platform will include, and that includes the ability to capture consent, to request and do the authorization, and all the other interfaces, including with local information management systems, and with those interfaces with the Genomics England, NHS data storage, and the UK genomic knowledge space, if consent has been given. So it gives us the ability to have a comparative data set across the whole of the NHS genomic pathway to drive variant interpretation, clinical phenotypic interpretation, given that we will expect HPO terms to be captured, and through the tool that will be applied, through the creation of a genomic health records in a standardized approach to additional findings, but importantly, for the very first time, to think about clinical effectiveness and implementation research in a very different way. And in the two sort of purple boxes, really to use this to drive new relationships with industry for clinical trials and patient cohort benefits, but also for the discovery end of this spectrum. And really, just to finish with the last couple of slides, this fits very closely with what our Chief Medical Officer called for in terms of a need for a rethinking of the wider social contracts for medical practice and medical research in the UK, and links with that. We will also be taking into account frameworks for data sharing in both the context of the National Data Guardian on genomics, even though there's some evidence being generated on genomics, and the recognising that the sharing of data is critical to ensure that patients get an enhanced diagnosis. But the fact that the National Data Guardian will not be producing any more genomics data sharing information, this will be the subject of an ongoing set of developments by ourselves. And you've already heard from David really eloquently on the EU General Data Protection regulation. And in NHS England, in conjunction with NHS Digital, we'll be developing new NHS guidance to continue to support compliance, but particularly a layered approach to consent. And really just to finish then, consent, we'll evolve the consent process that we're using in the 100,000 Genomes project for the future Genomic Medicine Centre, but it will be a hybrid and layered approach, and including longitudinal life course data, follow-up via EHR and registries to particularly inform that national clinical effectiveness. But what the whole of the NHS will be moving towards is data being collected once, shared and used for multiple purposes, and we will be linked to this new layered consent, partnering and benefits model for the future in terms of the health system. And I just wanted to finish really by echoing a number of things I've heard today, is particularly because we're in Orlando and we're near the Kennedy Space Centre, in terms of really achieving everything that the Global Alliance, but certainly what we want to achieve in England, we need to ensure that we embrace all the different members of the multidisciplinary team and multi-professional team across many sectors if we're really going to realise the ambitions and the visions. And finally, we very much believe that integration and collaboration is everything. And that's between academia and healthcare systems, between patients and professionals, with industry, but also with international collaborators. And I really hope as we go into our learnings system and approach from healthcare system implementation, that we can see a number of projects emerging under the Global Alliance. And leaders will need to work collaboratively to change practice and to establish these partnerships, to contribute to an international integrated network that involves patient representatives as well as professionals if we're really going to drive this forward and drive the innovation pathway at the bottom. And to recognise success means we've got to develop standards, purpose and vision, as well as common protocols. Thank you very much.